I'm Dr. Matthew Gloudeman. In this video, we're going to be talking about a sensitive topic, DNA CPR forms or do not resuscitate forms. What are they, and more importantly, what they're not. I'm also going to tell you how to spot a clinician who's not very good at having these conversations by the first question they ask. And then finally, we're going to talk about some of the statistics and risks that are involved with CPR that we're told as clinicians not to share with our patients and their families, but I do it anyways because I'm very open, and honest with my patients and their families, and I try to explain what leads me to my clinical decision making. Now, I appreciate this is a sensitive topic. If you want to have a detailed discussion with somebody, speak with a local healthcare professional. Equally, I appreciate that different cultures have a different mentality about this. This is what we do in the UK, and I'll explain why. So, there's a full disclaimer and details down below, but if you want to know what a DNA CPR form is, it's essentially if you have a cardiac arrest or a respiratory arrest, that means your heart or your lungs stop working, we put a form in place so that we let you go peacefully and comfortably with dignity. And a lot of people misunderstand that as the doctors are giving up on me, that they don't think I'm going to live long. Not at all the case. We're looking at your clinical fitness based on your past medical history and then trying to make a judgment call whether or not CPR will work. So we still take you to the hospital if you have an infection, if that's what you want. We still take you for surgeries if we think that you're fit for a surgery. If you have a fracture, we'll try and sort that out for you. It's literally, if your heart or lungs stop working, we let you go peacefully and comfortably. There's a whole branch of medicine called palliative medicine, which highlights for patients dignified ways in which they can die. And it's really important to me as a clinician that I don't put undue harm and suffering on someone, especially at the very last moments of their life. There's this imaging study that was done of a patient that had a heart attack while their brain was being scanned and their memory centers were lighting up. So a lot of people say their life flashes before their eyes, and maybe that's the case. We don't know for sure, but it's a beautiful but also tragic way to find out that in the last moments of our life and shortly thereafter, those memory centers are lit up. So I don't want to cause undue harm and suffering for someone that I don't think this intervention will work for them. Now, how do you spot a clinician that's going to do this conversation badly? It's the first question they ask, which is, if somebody asks you, do you want to be resuscitated? If that's their first question, they're not good at having this conversation, in my opinion. Why? Most of the time, clinicians will initiate this conversation because they think you're not fit for CPR. I'm not asking a fit young 20-year-old, do you want to be resuscitated ever? Because I assume that they will, because why wouldn't I? But if you are in a frail state, if you've got a lot of multiple problems, you've got heart failure, lung failure, you've got dementia, you've got other medical conditions, we are asking or talking about this topic because we want to prevent undue harm and suffering for you and your loved ones in the event that something bad were to happen. So if they ask you that first question, it's like a surgeon who doesn't think in the back of their mind, you're fit for surgery, saying, hey, do you want a surgery today? And then you say, yes. And then they either have to make one of two decisions. They have to tell you why you're not fit for surgery, which is a very challenging and difficult conversation, especially if they ask you if you want to have this surgery. The second one is they ignore their own medical knowledge and give you a surgery they don't think you're fit for. So CPR is the same way. We're not expecting as clinicians, family members, or patients to understand whether or not they're fit for that intervention. That's our job. We have to make that difficult call. We have to explain to them sensitively with compassion what CPR is and what it's not, and then we have to tell them why we think. The way I start this conversation always is, what do you understand about CPR? And then they tell me, and then I explain to them what it is. It's mostly, and the most importantly, compressions on your chest. So that pumps oxygenated blood to your most important organ, your brain, and then we're trying to keep your brain preserved and the rest of your organs preserved until your heart starts working again. Sometimes you get shocks and rhythms that can be shockable. Most of the time they're not shockable. It's not like the movies where you shock the heart and they come back to life in a second. It's not what CPR is. Most are non-shockable rhythms. We use medication and mechanically pumping to get your heart started again. And then there comes the statistics, which we're told not to share with our patients. It might be a British cultural thing. I think a lot of times British people will kind of say things in a roundabout way as opposed to being very direct. I'm from the States. My style is different than a lot of my colleagues. I remember when they were introducing that patients could read their medical notes and everyone was a little bit nervous about it. And I didn't understand why. And the reason I didn't understand why is because I tell my patients what I'm thinking. I tell them the reasons behind my medical logic, and I type that in the notes. So if they read the notes, it's just a reflection of the conversation we had. If I think someone might have cancer, I will tell them, look, some of the symptoms you're describing could be cancer related. So I will investigate, I'll do these tests to see if there's something worrying going on, like cancer. We cast a wide net to catch the very few. Times when I'm digging in for cancer is maybe 2 to 5% of patients. So I'm packaging information so they understand not to worry, but to understand why I'm doing what I'm doing. And they know that I'm investigating for cancer. And when cancer shows up, then they've been already pre-prepared. Whereas they're blindsided sometimes if they see a request form that says CT scan query cancer. So honesty is important for me. That's why when I talk about CPR with my patients, with their families, the risks and the statistics. So the risks. When we're mechanically pumping your heart, we almost always fracture ribs. I've been involved in at least 50, maybe 100 or more resuscitations in the hospital because I used to carry the crash people a lot because I wasn't nervous about going in and helping people or trying to help them. But we almost always fracture ribs, especially for frail elderly people. The other thing is hypoxic brain injury. So your oxygen isn't getting into your brain, so your brain cells die. So you might not come back the same way you came into that arrest. Other ones are strokes, because we're kind of causing turbulent blood flow. That can throw off strokes. So if you've got risk factors like smoking history, if you have diabetes, if you have cholesterol problems, heart disease, previous strokes, those all factor in and can make things worse for you. On top of that, it usually means a longer hospital stay and potentially some pain and suffering if you do survive that intervention. And then you ask how many people survive. In the community, it's very difficult to get a heart started up again if it stops. You need someone there that knows how to deliver these good compressions as soon as possible within minutes. I've had one patient survive 3 cardiac arrests in the community. It's a walking miracle. It was amazing. But that is a rare case. It's usually less than 10% of people survive if they have a cardiac arrest in the community. In the hospital, we're a bit better because we've got a crash team that comes out quickly. But even surviving that hospital admission is only 20%. So we're doubling your chances almost, but 50% survive the initial problem, which is this cardiac arrest, but only 20% actually leave the hospital alive. So it's very difficult, and that's why we as clinicians try and identify patients that we don't think would be suitable for that intervention, let them go peacefully and comfortably with dignity. That's really important to me as a clinician. That's why I have these conversations proactively. There's also emergency healthcare planning that I'm very passionate about and kind of a clinical expert in a field that doesn't exist yet in that regard. So there's more information about that down below in the description box as well. But I hope this video was helpful for you. If you're worried about this, please contact a local healthcare professional. If you like these videos, I'm happy to make more of them. I'm just trying to help as many patients and families. So if you could subscribe, you can get more free information from a doctor.